you all know that October is considered as a Cancer of the Breast Awareness Month. And what we were thinking about to educate the people, particularly with me, I have with me is Dr. Gurpreet Singh Lamba, who is a cancer specialist. He works in the Homedale area. He has a different office and he goes to the Jersey Shore Medical Center. The other person I have is Dr. Hetal Gor, who is a OBGYN doctor, well known in the Hackensack area, and she has a very good practice. So we are going to start with Dr. Gurpreet Singh Lamba. Dr. Lamba, can you give us some little bit background of the cancer of the breast?
So first of all, thank you very much for having me at the program. Breast cancer, as we know, this is our Breast Cancer Awareness Month, and breast cancer is one of the most common cancers that we see. It is seen a lot in women. A little background about this, it's expected that in 2020, we're going to have about 276,000 cases in the US alone with breast cancer in women. In addition, we'll have about 2,500 to 3,000 cases in men. So that just tells you the magnitude of the problem. The incidence has been slowly rising since the 1980s, initially because of the mammogram that was, when we started doing screening mammographies. And then after that, when a lot of women were taking hormone replacement therapy, the incidence went up a lot. So far now that has stopped with the menopausal woman. But still, we see a lot of breast cancer, different stages, and it's really a big healthcare issue.
Okay, so as you know, with all the disease, always the prevention is always a better than the cure, as you say. So what can we do about the prevention? So we'll start with the prevention first and then go to the disease plus.
So prevention so breast cancer is actually one cancer that, like you said very correctly, absolutely preventable. So there are things which fall into that with like risk factors. So if like women can work on the risk factors, that will decrease the chances of them getting breast cancer. The risk factors for breast cancer are genetics. If you have a family history, if you have a BRCA mutation, I understand we can't do much about that, but there are other factors we can work on, including lifestyle. And that also includes exercise, healthy diet. It is a well-known fact, even after you've been treated with breast cancer, your rate of incidence or the risk of relapse is much lower if you're more leaner and have less body fat. That's something we really emphasize on in our cancer survivors. So even if you don't have cancer, it's always good to lose weight, exercise. The other thing is about reproduction. Women who have kids later on in life are at a higher risk of getting breast cancer than women who have the kids earlier on. It has something to do with the amount of cycles that your breasts are exposed to. And the last one, again, is sort of a unmodifiable risk factor in our times is exposure to environmental agents like radiation and so on. So again, not something we can do much about. We have that all around us. But definitely, I think we can work on at least a couple of the risk factors. And once we've worked on the risk factors, after that, we can then talk about screening and things like that. And that can lead to, even if not prevention, at least early detection of what we call carcinoma in situ or stage 0 breast cancer, detection of cancers at an earlier stage, and also will help prevent in secondary prevention. Secondary prevention is when somebody's already had breast cancer and we try to prevent the cancer from coming back. So definitely it's something that we can work on.
Thank you, Dr. Lamba. That was nice. But let me ask Dr. Hetal Gor, who is an OBGYN, but many women goes to her for the OBGYN. So Dr. Gor, what are the screening methods and how open and what age you should start the screening?
So thank you so much, New Jersey State API, for doing this program for breast cancer awareness. And as an OBGYN, we are like a first line of kind of defense woman has for early detection, for recommending treatment, etc. So to add to the risk factors, right? Somebody who has early menarche, that means they started their periods earlier on, somewhere around age 9 and 10, which we are seeing nowadays as the childhood obesity has gone up. The menarche is earlier on. Later menopause, that means somebody who doesn't undergo menopause by age 50, they are at 52, 55. So the more the number of menstrual cycle, they are at higher risk. Somebody who is starting the fertility late, more and more women are very career oriented, and what is happening when they are postponing their childbirth after age 35, etc., not only they are at risk for pregnancy-related complication, Down syndrome, but also their risk for breast cancer starts going up. Somebody who has infertility, who never got pregnant, has a much higher risk. Somebody who has had child but didn't breastfeed the baby is much higher risk. Also, the first degree family, right? So if you have a mother or a sister or a daughter who is diagnosed with premenopausal breast cancer, they're at much higher risk for developing breast cancer. So these are the risk factors that we kind of, put into consideration while we are discussing with the people about, how are we screening and how are we taking care of this. Genetic factor is a big factor, and that's why we ask the family history, not only just breast cancer, but uterine cancer, ovarian cancer, colon cancer, all that is puts the woman at a higher risk. Race, of course, Indian, this program is geared to Indian, but Ashkenazi Jews, they are at much higher risk. So knowing your patient and their risk also is a very important factor. Now, once we have this patient, as you said, when the patient has come to you, how do we do it? So first and most important thing that I teach my patient is their own breast exam, right? Which is really a very important tool that a woman has. We try to tell them to do a breast exam after their menstrual period and check the breast, for Sunday after their period, etc. And we teach them, either they can teach them in a circular manner, they can go, or they can go in a linear manner and then express if there is any discharge. So those are some of the things that we really tell our patient. As far as the mammogram, when do we start doing them? The recommendation is to do, if there are no other risk factors, then to start doing it a baseline at age 35 and then start at 40 onwards. Either one, depending upon the risk factor, they can do every 2 yearly till 50, or some, recommendation by other association is to start doing yearly from 40 onwards. One important factor, that if somebody has a family history of breast cancer, if the mother or somebody has had breast cancer, then you will start 10 years before they were detected. So if somebody's mom had breast cancer at age 40, we would start monitoring their daughters at age 30. So that's kind of like ballpark age. But it's also very personal history. If you feel something, we tend to investigate earlier.
So Dr. Gor, thank you for that good introduction. And so the ideal is at 35 years of the age, they should start screening the. But
there should be a baseline. It's a baseline at 35, and age 40, you start doing them.
And if you have a risk factor, which is genetic, is most, and if you had a family history, you can do even earlier than that, if you have suspicion. So that's very good introduction. Also, it's a very good sign to do. So what I would like to do is, I want to get Dr. Lamba to see, the cancer of the breast is always considering the woman, but there are cancer of the breast for the men also. Can you light some on that, Dr. Lamba? Because we always, when they think about the cancer of the breast, they think about women, but there are also the men who can have a cancer of the breast, right, Dr. Lamba?
Yes, no, and I definitely have patients, male patients with breast cancer too. So it's definitely something we like to check for if a male complains about a lump in his chest or something like that, and then ended up going a similar workup like what Dr. Gor was describing with mammogram and ultrasounds and so on. Like I said earlier, it can happen. 99% of the breast cancers happen in women. 1% in men. About 12, we expect in 2020 we're going to have about 2,600 or so male breast cancers in the US alone. So it's not as common as a male would get lung or prostate cancer, but definitely something to watch out for. Treatment-wise, they are treated similarly. So we kind of follow similar guidelines, but because in males, this can sometimes present at a more advanced stage because the screening doesn't happen. Even having said that, though, if you just look at stage-to-stage mortality between men and women with breast cancer, men tend to do a little bit better in terms of mortality and how they do with the breast cancer at that particular stage-to-stage comparison. Nobody really knows the reasons for the difference. We believe it's probably some hormonal differences that account for that. But also, whenever a male has breast cancer, it's almost imperative to look for the hereditary breast cancer, the genetic mutations with BRCA1, BRCA2, and so on.
Okay. Thank you, Dr. Lamba. So now we can come back to the risk factor modification, Dr. Lamba. You know, there are risk factors, there are certain risk factors you can modify, certain you can, like genetic, you cannot change at all. But what are the risk factors that you can modify? Like I just tell you, I know one is smoking is the one of the risk factor for that, which you can modify. But what are the other risk factors that you can modify?
So definitely, like I touched a little bit about this previously. So smoking, yes, definitely we have to modify. The other major one is dietary lifestyle changes, which is having a lean body weight, exercising, watching the diet, have less amount of body fat. That definitely decreases the risk of breast cancer. I mean, we have to remember breast cancer in a lot of the patients is a very estrogen or hormone-driven cancer. And some of us believe that estrogen is only made in the ovaries, but that's not true. Estrogen can also be made in the fat, and a gland next to the kidney is called the adrenal gland. So the less fat we have, the less the chances of a lady getting breast cancer. Another thing that we can do to prevent is a baby aspirin. Some people do believe in it. There are studies that to help that prevent it. It's not 100% established yet. There's also data to show women with normal vitamin D levels will do better or have less breast cancer than women with lower vitamin D levels. Other than that, like Dr. Gor was also saying earlier, with the self breast examinations, with the having kids earlier in life will definitely also help prevent them from having breast cancer.
Thank you, Dr. Lamba. I'll tell you one more too. Yes, people think about exercise, I used little bit different word, move your body. Because, when some people you take exercise, I cannot do because I have a arthritis, I have this and this. So the way I say to the people is move your body. What it means is, even if you are watching the TV, let's say, everybody watches half hour to 1 hour at TV. During that time also, you can move your hand like this. You can do your leg. It's an exercise. In short, what it is that you have to do move your body whichever way, not just sitting still. That is what I believe. And that does make a difference. If you think about that, if you are watching the TV for 30 minutes, even if you move your arm 20 minutes, it's a good exercise,
Absolutely. It's a very well put way to just have them move and exercise. That definitely helps. And
also there is one factor, what I heard, is the tall woman can get this CA breast chances are why. That is one of that I was reading then, and it said, that is one of the risk factors which we didn't realize, but it is a tall woman also can get this risk factor to increase. So now the modification why, so genetic we cannot do it. We can do the exercise which is, or move your body. That is more appropriate word to me than, because some people will tell you, I can't do exercise. They mean exercise means running or jogging or bicycling, but it's not that always. Move your body. That's what main, I believe in that. What about the diet?
Diet definitely, diet definitely will help decrease the risk of breast cancer. Again, having a less fatty diet, less fried foods will definitely help. People also believe in a plant-based diet, which is very helpful for some of our Indian communities. So those things are also shown to decrease the risk of breast cancer. But again, it all comes down, the way I look at it, into lean body weight. Uh,
And I heard that plant-based food is much better than the animal-based food, you know.
I would like to add to that. There are studies which have proven decreasing animal fat, right? That increases your longevity. It decreases the number of cancer, not just the breast cancer, but overall cancer. And breast cancer is directly related to the BMI. So somebody who is obese, morbidly obese, has much higher risk of developing breast cancer. So in the modification, the one thing one can really tell the patient is about losing weight. And I think we can't emphasize more. Alcohol, I think, is a big risk factor as well. So when we are telling about behavioral modification, reducing the number of alcohol, the alcohol studies goes back and forth. Sometimes one glass of wine is fine. Sometimes, no, you should not have alcohol. So definitely very important to cut down on alcohol, cut down on meat, cut down on fatty food, reducing the BMI, exercise, breast exams. These are something one can do for prevention as well as dealing.
Thank you, Dr. Gaur. That was a good one. So let's say a patient who has find the abnormality of the breast. So the next thing that what we can do for that woman, can you tell?
Sure. So what happens when the woman comes to us? Most of the time, they'll come to their OBGYN that I felt some lump in my breast, or it doesn't feel right, or I have some pain. Most of the time, we would like to do a breast exam, right? So as soon as the patient comes, we with those complaints, we do a breast exam. If there is a mass which is palpable, we kind of show the patient where the mass is, and we record this in our notes as well as charts, as well as when we refer them for mammogram or sonogram. So usually these people will go to first either an ultrasound, and if need be a mammogram, and if need be a biopsy, either ultrasound guided or mammogram. So it depends on the age, about the risk factor. Once you start either with mammogram if somebody is elderly, or you start if somebody is younger with an ultrasound. But not all lumps are bad, right? So sometimes they can be cystic lump, which can be just fibrocystic breast. Even if it's a solid tumor, sometimes it can be what we call as fibroadenoma or fibroids of the breast. So I want to tell all our viewers that not all lumps are bad, but if we feel something, it's hard for one to know which ones are a good one and which ones are bad ones. So that's why breast exam is very important. Go for your annual exam with your OBGYN, and they can feel your breast for any lumps. And if there are any lumps, we follow it either with ultrasound or a mammogram.
Thank you, Dr. Gaur. I'm being the infectious disease. I'll tell you the story that the breast cancer not always present with the lump. I see that we have been called for and we see the patient has some ulcer on the breast, and it's there for quite a bit time. And the patient thinks, it's just something breakdown of the skin and all that. But those are also the symptom of the CA breast, and we have diagnosed. And when we suspect that, then we do biopsy and find out whether it's really infected or not, because sometimes they have basically ulcers on the breast, and that is not healing.
That's a very good point, Dr. Shah. There are certain breast cancer, I'm pretty sure Dr. Lamba can elaborate, which are called inflammatory breast cancer, where it starts, it looks like as if there's a mastitis, it looks like there's an infection. The rare ones, we do see them in sometimes postpartum patient, but those who look as inflammatory breast cancers, those tend to have a really bad prognosis. So yes, so there is a condition called, which looks like an infection or inflammation of the breast, but it's a cancer.
Mhm.
Yes, no, and like Dr. Gor said, yes, those are the more aggressive cancers. We definitely treat them. We definitely are able to manage them. And even though they have a bad prognosis, bad is now kind of become a very relative term in management of breast cancer.
Right.
We're doing way better than we were doing before. And I'm pretty sure we're going to talk a little bit about the stages and the treatment of breast cancer in a little bit. But we're doing new things.
Okay, thank you, Dr. Lamba and C. So next thing, let's say patient is diagnosed with the CA breast. What can we do further? Whatever region, possibly the most open they're doing by biopsy report. So what do you do next, Dr. Lamba?
So before I actually answer that, I want to just go a little bit back because a lot of our viewers are going to not know this. So the first thing is, when you get an abnormal lump, you go get a mammogram, and then the mammogram basically tells us grades the lesion they see on a scale of 1 to 5, and that basically tells us whether it's absolutely benign, possibly benign, or suspicious to be cancerous or something like that. And as long as you are, they call that BI-RADS staging. So as long as you're 1 or 2, you're okay, and they just tell you to get another mammogram in 6 to 12 months. But when you kind of get into 3, 4, 5, that's when the next workup starts, which would include an ultrasound or possibly a biopsy. A biopsy is where with an ultrasound, they feel the lump or see the lump and stick a needle into the lump and send a little piece to a pathologist to further evaluate what they see. After the biopsy, there are other tests which may need to be done, which can be an MRI or blood work. Sometimes we have to do a bone scan. A very frequent question they ask me is, why can't we get a PET CT scan? We do PET CT scans also for breast cancers, but it's not for everybody who gets diagnosed with breast cancer. So basically, once you get diagnosed, after that, you have to go see 3 different doctors. One would be a breast surgeon, a medical oncologist, and a radiation oncologist. And between the 3, that's a multidisciplinary approach. And between this team, we come up with a management or a plan, which can include surgery, especially if you are a stage 1, stage 2, or stage 3, which can include chemotherapy if you need it, which will include radiation if you need it. And sometimes the chemotherapy will be before we do the surgery. Sometimes you may not need chemo. Sometimes the chemo is after we do surgery.
Okay, Dr. Lamba, that was very good. So once the staging, what we call it, staging means it's what stage of how much is, whether it's a localized or it's a spread disease and that. So what the next thing comes, the treatment, obviously.
Yeah, so
can you say some treatment?
Can I add something, Dr. Shah?
Sure.
So breast cancer now is considered more like a systemic disease, even if it's earlier on. And what the treatment they are gearing, and I'll let Dr. Lamba expand on that, but mainly they are doing more and more conservative breast surgery. Before we would do mastectomy, we would do a really big debulking operations, take out the breast, take out the lymph node, nowadays, there are more and more surgeries done as a conservative treatment, mainly doing lobectomy, just taking out the part or taking out the lump which is there, along with what's called sentinel lymph nodes. When the dye is injected, if the lymph node picks up that dye, those where the metastasis has happened, and those only lymph nodes have been taken out. And then they are giving really, really a strong chemotherapy, and if need be, radiation. So now the approach has become really into what is called as more and more conservative treatment and doing more, aggressive chemotherapy and radiation as such. So the guidelines have changed.
Yes.
Thank you.
Guidelines keep getting updated very, very frequently as more data keeps getting published, as there are more drugs that get approved for breast cancer, as we have new medications out there and stuff like that. So definitely, so yes, lumpectomy is a very important top point that Dr. Gor brought up. So we are doing, initially a lot of patients were just getting mastectomies, but then later on it's almost like you can do equally well if we do a lumpectomy followed by radiation, as long as a lumpectomy is feasible, depending on a lot of factors. If you end up still getting a mastectomy, we almost always will try to get a reconstruction done at the same time. A lot of women ask us, why lumpectomy and not a mastectomy? Because the data is almost the same. Lumpectomy followed by radiation may be similar to a mastectomy. But in the future, I think it leads to a lot of psychological impact for a woman if we do a complete mastectomy, especially if you're very young. And having that psychological impact makes a lot of difference. And a lot of women ask us this at diagnosis. No, I don't care. Just take it off. But the problem is they live long. We have, patients with stage 1, for example, 98 to 100% of patients will be alive at 5 years, from breast cancer. From stage 2, it's like 90 to 95%. For stage 3, it's it's over 65%. Now, those are, so more than likely you're going to be alive. And the psychological impact then hits them after that 5 years, after the 10 years have passed.
It's a very important point because the body image, right, gets so affected for those people. And now, as Dr. Lamba mentioned, breast cancer has become almost like a chronic disease if caught in an earlier stage. So these women are living with this, and it definitely has a major impact on the body image, how they perceive themselves, and the impact they have. So more and more breast surgeries are conservative, trying to have a balance, not to do too much and not to do too little, just to do the right thing.
Thank you, Dr. Gor and Dr. Lamba. So I want to move to the next phase. As you know that you told that, the partially sometime treatment is the mastectomy. So there is now a lot of things can be done, including the prosthesis, to get the image of the woman, because they have suffered. They may not realize immediately, but sometimes later on they realize that, they have something defect in their body. And we get what is called the prosthesis part of the disease, and that where is involved the surgeons, plastic surgeons also, and that part of the treatment is going on there, and which is where available. And sometimes if a patient goes outside, they may not, the other person who doesn't know them, they may not even know that patient had a lumpectomy or anything done, So
Correct. So now what they are saying, Dr. Shah, what the plastic surgeons are doing at the time of either lumpectomy or if mastectomy is needed, if the size of the lump is big or it has affected the skin, they are doing abdominal graft at the same time. They take a flap from the omentum fat below the stomach area, and then they flip that fat, and put it inside. So they are doing much better surgery. So the breast feels almost like a natural. So the care for cancer has changed so much, and plastic surgeons, along with the breast surgeons, are doing amazing job.
Yes, it is a very well progress in that. Now coming back to the radiation, so how Dr. Lamba can answer this question. So how do you decide that you want the chemotherapy first or the radiation therapy first, or you combine with the surgery also? So
usually that's why we have a team of doctors. The standard rule is that the radiation is almost always after the surgery. So the biggest thing is whether we give chemo before surgery or give the chemo after surgery. Until about, and that all depends on the stage. And we know there's, like, as we said, stage 1, 2, 3, and 4. And just to kind of give a brief overview on that, stage 1 is like when it's a very small mass in the breast. Stage 2 is when, let's say, the mass is a little bit bigger, more than 2 centimeters, but still less than 5 or 6 centimeters. Stage 3 is when the the cancer has actually spread to the lymph nodes. And stage 4 is when the cancer has spread beyond the lymph nodes to another organ. So let's tackle the easiest one first, which is stage 4, where obviously the only treatment mainly is some sort of hormonal pills, chemotherapy, stuff like that. But when stage 1, 2, or 3 is where we decide whether we have to go chemo first, hormonal therapy first, or surgery first. Usually, until about 3 or 4 years ago, we were almost always giving the surgery up front and then follow that up with chemo and radiation if you need it, especially for stage 2 and stage 3. Now, as in the last couple of years, there's been a very major push to do what we call neoadjuvant chemo. Neoadjuvant chemo means chemotherapy before surgery. We have seen that by doing that, the surgical outcomes are much better. We are able to convert mastectomies into a lumpectomy and save them with the whole dilemma like we talked about earlier. And sometimes we've actually had surgery done and there is no cancer left behind. And that's the excellent prognosis that we get. We still end up doing the surgery for them. But we call it downstaging of your cancer to get a better cosmetic outcome. The patients who get the neoadjuvant chemo do almost as well as if they were going to get the chemo later. Some of us believe that they actually do better because we are hitting the disease systemically with chemo going everywhere in your body. So even if like one cancer cell has escaped the breast, we can kill it. As opposed to if we do surgery first, we're just taking the mass out. It's a very, very individualized approach. Again, this is a very vague, very high overview. We have to check hormone status. We call ERPR. There is something called HER2 status we have to look at before we decide what your treatment options will be. There are all kinds of genetic tests we have at our disposal called Oncotype, MammaPrint, Prosigna, just to name a few. And basically, there's a lot of information that has to go. And it's a very, very personalized approach.
Thank you, Dr. Lamba. Dr. Gor, you want to say anything, add to this?
No, Dr. Lamba did explain. Usually nowadays, depending upon the stage, as he explained, the staging is called TNM staging, the tumor nodes and metastasis. Most surgeons prefer to start with the chemo first, and keep the disease localized as such, then do the surgery, and they have to wait at least 4 to 6 weeks for the incision to heal before they give the radiation. So mainly, as he suggested, it's a combination treatment. Also, they do what's called hormone receptor testing, right? So we see if there are estrogen receptor, progesterone receptors, and then there is a hormone modulation can be done. So it's a multi-specialty teamwork to take care of somebody with a breast cancer.
Thank you, Dr. Gor. I think that this is overall we have done. The topic has been improved, including the prevention, diagnosis, treatment part also. I want to check with ITV, any question come up from the audience or anything. Is ITV on? I don't think anybody has answered any question. So let's begin to Dr. Gor. You want to say something because we still have a time, but I don't see any audience on the phone. So anything specific you want to say about?
Sure. So as we discussed at the beginning, for our viewers, few important points. Breast cancer is the second leading cause of cancer-related death in women. Around 1.5 million cases are there, and the mortality tends to be anywhere, which can be around 200 to 250,000. So it's really a very significant disease. 1.5 million cases and 500,000 deaths can happen because of breast cancer. Now, it's very important we pick it up at an earlier stage. So either an exam or a mammogram, which is really a hallmark to pick up this cancer. Some high-risk people, we do what's called MRI to pick it up, but it has it sometimes can be non-specific because it picks up lots of other non-cancerous cysts as well. But for some people, we do recommend MRI. Important thing is to go for the exam, to do the follow-up, to know your history. If you fall into any of those risk factors or any of your family member has it, please be very, sometimes some people get worried, oh, I don't want to know about it, so I don't want to go. You're just hiding it under the rug. The cancer just doesn't go away if you don't go to get an MRI or ultrasound done. So if you feel something, please be proactive and show it to your doctor, and they will order the needful testing. And if you do get breast cancer, if it's diagnosed early, it's really something that we can treat it. Nowadays, the chemotherapy have improved so much with minimal side effects. There are other hormonal modulation, etc., to be done. As we discussed, the surgery doesn't have to be a mastectomy or a disfiguring surgery as such. There can be lumpectomy. If need be, they can do a flap. They can reconstruct the breast. So the management has really improved in last 10 to 15 years. So I want everybody to know, first look for cancer, do your exams, and if you do end up with it, it's not so disheartening. Of course, cancer, anybody hears gets scared, but the management has improved drastically.
Thank you, Dr. Gor. Dr. Lamba, you want to say the final words?
No, so definitely. I mean, thank you for the opportunity, but definitely the main thing is screening. Like Dr. Gor said, you have to go for your screening, self-breast exams. Yes, after that screening, even if you get diagnosed with breast cancer, it's not the end of the world. That's what I can tell you. There is a lot of treatment options available. There are a lot of well-tolerated treatment options available, whether it's chemotherapy, surgery, or hormones. Treatment is very, very individualized now. Even if it is metastatic disease, we have things called immunotherapy available. We have hormone pills. We have multiple rounds of chemo available, and it's all becoming a chronic condition. You just have to hang in there. There's more data coming out, and people are doing so much better than what they were before.
Thank you, Dr. Lamba. So let me close out with saying that thank you both of you, Dr. Lamba and Dr. Gor. We had a very comprehensive review of this disease. And I will tell you that the cancer of the breast in United States is the second leading cause of the death due to the cancer. And it is also preventable disease, and people need to be aware of what are the risk factors they have, what is there, and start screening the mammogram, which saves the life also, and detect early, and we can treat early. As always, prevention is better than the treatment, and if you have disease, early treatment is better than the late treatment in this case, any disease particularly. So I want to thank you, both of you, joining, and I want to thank ITV Gold. I don't think that we have any question coming up from the audience or anything, but thank you very much for joining this, and good luck, good evening to everybody. Thank you.
Thank you.
Thank you.